Now it is the time to introduce a very dear speaker, Dr. Antonello Pavone, that will speak to you and to us about how to obtain the correct balance between swallowing, chewing, and smiling on adult patients. Dr. Pavone is originally from Italy, but he's also working in Switzerland. He's speaking perfect French, and that's the language that we choose today to make you the lecture. We were discussing a lot because Antonello was making a lot of lectures about froggy mouth, all of them more interesting than the previous one. And I have to say that it's one of the speakers that was impressing the most my dad when he was seeing the little repetition, having such a functional view on a subject that usually people are putting on the side. The functional balance is something that is so important that it has to be noticed. I think that it is the future of all the prosthetic and aesthetic treatments to also take into consideration the functional part, to have a full rehabilitation and to be able to bring back a total, full, beautiful aesthetic. We have to take this part into consideration. Antonello is really a pioneer on this field, and he is going to make you a wonderful lecture that I advise to all the people that make at least a little bit of prosthetic to see. I have to say that I was seeing one of the clinical cases that was impressing me the most with a patient that I was really not believing in which order was the before and after, because really on the after, for me, this patient was 10 years younger by far, if it was not clear that it was the before and after like that. So Antonello, thank you so much to participate to those Froggydays. I am now letting you share your PowerPoint and start your lecture. Antonello, c'est à toi, et en français.
Thank you very much.
Thank you very much. Is everything clear? Can you hear me? Okay, so good day to all of you. It is a great pleasure and honor for me to be invited into this Congress that was organized by Guillaume or William. And I will indeed try to tell you a little bit about the use of Froggy among adult patients. So I am as you know, a dental technician or prosthetist more specifically. So I'm going to try and summarize the complex system of our adult patients with a final goal of reaching not only a nice smile, but also optimizing the chewing as well as mastication functions within and among our patients. So before anything else, I would like to start by thanking Professor Fellis for the initiative of organizing this seminar and William for his invitation. And also thank all the patients who, by their lending themselves basically to the experience and using the Froggy device, kept training me on the field basically, and to perfect and to fine-tune all our knowledge and belief and creed as well in this project. So all the patients who will be mentioned in this presentation will have been treated by my professional colleague Antonio Pavone, with whom I developed all those interdisciplinary cases. And I would like also in passing to thank those very patients who basically injected so much positive energy into our daily practice. And at last, I would like to thank the whole of our functional brigade, as I call them, with Dr. Gregory, who's a sort of revolutionary on the field, who's helped me, I believe, very much proceeding on this learning curve and making sure that we stayed positive and enthusiastic about all this project. So, as a prosthetist, I always try to be as clear as possible in the goals and ambitions we're setting ourselves. That's to say, trying to find a balance between the biological constraint or goals, of course, and the aesthetic ones, but we want to make sure that the functional aspects are growingly performing, because they usually turn to us because these systems have gradually become dysfunctional, and they will obviously not age in a satisfying way, as the challenges that they'll be confronted two will be growingly complex. And yet I want to make sure that they can smile. So over the last years, before managing the last and final phase of our patient's treatment, I always ask myself about the root causes of this system development. Because it is only when you handle youth and youngsters' problems that you begin to understand better why we are usually the people they turn to at the age of 50 when their mastication or functional systems become more complex because their teeth are aging, basically, and they are confronted to serious class 3 dysfunctional cases that definitely need to be improved. We also, nevertheless, need to bear in mind the very major important aspect of their well-being, their wellness, the emotional dimension, that's to say, namely, make them smile. So this is really the sort of dual aspect and goal that we should set ourselves, make sure that they can function optimally and then be happy, basically. So the first question we need to ask ourselves when treating adult patients, I believe, is who and when is trying to develop such a system. Who is basically contributing to the complexification of the system. So we know that it's partly due to genetics. And as Professor Fellis well explained using the following metaphor, we know that perhaps the genes are responsible for the score in a music of a major composer or work, but the performance as it is enacted and performed by one or another orchestra matters just as much, and that is what epigenetics is all about. And that brings in all the factors of your experience and your lifetime hygiene or routine and what you've been doing and accumulating in terms of precedent since your birth. And so this is really what we purport to understand. What can bring about such dysmorphias by the age of 40s or in your 50s? And amounting to such dysmorphoses, which obviously require to be perfected in terms, as we said, in terms of functionality as well as in terms of aesthetic, so that the orchestras can basically produce their most harmonious performance and work. So that is also implying that we need to get into the nitty-gritty details of this cycle of swallowing, chewing, and smiling, and the bilateral balance between all these different functions, for lack of which the system will not evolve harmoniously, because it's more than 1.5 million years. Now the system has organized itself through a balanced function in order to become as consistent as possible and optimal in the process of evolution. So since 1.5 million years, humankind has turned into some nearly ideal or at least adequate result that should be able to operate in a satisfying way. So we need to revert to certain benchmarks in the history of mankind's evolution in order to understand better how the phylogenesis of this system came about and to manage the system optimally. Because the problems that will be interesting us today, obviously, and in our profession, are mainly malfunctional occurrences. And they're usually due to the fact that the suction system has not matured functionally in an adequate way. So, as Professor Fellis explained really well, these things are intimately connected, and nutrition has a lot to do, and nutrition change, obviously, over the last 10 million years is for a great part responsible to these changes, because man has basically more and more suffered from hypofunction. So what we need to understand is how these primary functions of the system of the viscerocranium were affected by these external changes, and what new functions came about with this swallowing evolution, or perhaps try to act on the chewing process in order to optimize the capacity of the whole maxillary apparatus in a dynamic way. So what is going to be our main objective in today's day when trying to treat those adult patients? Well, it is fight as much as possible against the shrinkage jaw epidemic, so to speak. This typically is the mouth typology that we've been observing. The adult patient ends up having to lose teeth because the jaw has shrunk so much with respect to the number of teeth present, and he nevertheless needs to bring it about in a coordinated and well-orchestrated way, making sure that one function is not obliterated by another one and that everything can be well integrated. So in order to avoid the domino effect, we need to recreate this domino effect by trying to start over from the swallowing and mastication process, clearly in their childhood. So, as we know, given that children are less and less breastfed and therefore not as spontaneously trained to proceed with suction reflexes or sucking reflexes as before, the prosthesis basically need to be integrated to this viscerocranium system, bearing in mind that the teeth are only the tip of the iceberg because there are more than 70 muscles, 5 cranial and 9 cranial and 5 spinal nerves that are part of this highly and extremely complex system. So it is not a random fact or accident of evolution, basically, that nature dedicated so many efforts in order to monitor all these important functions. The tongue is very small, but with just 17 muscles, 5 cranial and 9 spinal, again, nerves, which are connected intimately to the jaw and to the teeth. And this is an organ of major importance that really needs to be managed properly in order to age properly. So, phonation, the use of language in all sorts of functions are of paramount importance, and the cortex really needs to develop this management capacity all the way from the viscerocranium apparatus. So how can we make sure that the system is consistently developed? Well, the tongue should be in a resting position under the palate and should stay there most of the time. It is only when you swallow that it should push up towards the palate. Now, there are a lot of authors since the beginning of the previous century who already started emphasizing the importance of the tongue movements management and how to use it as a part and process of the orthodontic processes. We know that 30%, and I actually observed more than that in terms of percentage in the population, do suffer due to this shrinkage jaw epidemic and their nutritional habits change. They suffer from this palatal dynamic, altered palatal dynamic that leads to some dysmorphosis connected to the viscerocranium that can also take us all the way up to some severe dysmorphosis up to group 3. So this is nothing new, but such cases, even if we are aware of the tongue's importance, is that we tried to improve this position in with different techniques, with some aligning devices, We tried to modify and affect the consistency of the engramming process. However, unfortunately, most of the tongue-related treatments in the early days were never satisfying or sufficient in order to generate sustainable results, and that is why we're so proud. We were so proud to get some results with the first crossbite experiences, where the anterior prosthetic parts were respectful of the biology. So that was helped us and enabled us to recreate the patient's smile. But overall, the biology not only was respected structurally, but was also making allowance for the patient's evolution over time. So the patient's first reactions were positive, but we would still monitor its evolution over time. After the aesthetic prosthetic treatment, after a few years, the patient would come back to us and there was a major mechanic failure. Say if a tooth was broken, I just needed an implant and I could quickly fix that problem with a small ceramic chip. And after, at age 9, I did another check, and 11 years later, because she had stopped seeing me and had moved to Naples, she started suffering from another tongue-related problem, an anterior diastema. So we had overcontracted the arcades and closed up or tightened up the mouth exceedingly. So that was a bad balance between the functional and aesthetic aspects. So when we try to establish or recreate new systems of such complexity, we really need to make sure that all these aspects are put on a par and in a consistent way, as I said. So after years, we realized that this was a major functional failure of our planning process. We were confronted to diastems and excessive wearing, and the system became explosive. So we tried to perfect and remedy those major damages. So what are the major types of damages that we come across among our adult patients? Malocclusion is an obvious one that increases the diasteme, and also the dysfunctional problems connected to the cervical exterior pulls and triggers of the mandibule, basically, which can overload the external joints. So this is one problem, another one being that aging patients see an augmented risk also of those sleeping disorders. They can have occlusion traumas and periodontal traumas because of the accumulated deposits and the swallowing problems that haven't been solved. So this whole balance is affected by the presence of the Lyme scale, and also on an aesthetic plane, the labial contact is affected. So what should we do? in order to treat these pathologies, well, make sure that those three muscular groups work together, that they're never, bear in mind that they're never disconnected. When you're working on the mastication aspects, the suction and the swallowing muscles will also become stronger. So if you're operating a strong mastication system, you, without taking all of these factors into account, you can actually aggravate or worsen the dysmorphosis at the end of your protocol. So that is the reason why orthodontists try to reorganize the system, but if it's not taking into account all this domino effect previously mentioned about the muscular connections, we may generate a long-term failure. So dividing it the series or the set of patients in two, there are some that might explode in the long run, or others where, on the contrary, the muscular structure is too tight and they potentialize themselves and close up in an implosive way. And these are huge differences when we need to restore the system or improve the dentition, obviously, because there are wearing systems or results in a more horizontal or in a more protuberant way accordingly. So now quantity of signs can be observed in order to understand which trend we're surfing on. Basically, it's sometimes enough to just diagnose the shape of or the tension level of the lips or certain infection problems during the winter season, and then there's also another problem connected to the behind articulations. Can even affect the way you drink and eat. So the bite needs to be analyzed clearly when you have gingivitis problems, because the patient will obviously go for the anterior support if he has a biting problem, and then support this natural or easy trend with his tongue. Tongue is there obviously to compensate for the imbalances, the structural ones. So if the structural system hasn't been readdressed, you cannot re-educate the tongue, and vice versa, obviously. So this is the broader picture that you need to decide from when devising your strategy, basically. And you can see the extreme parodontosis problems and extreme cases. And we can also listen to the patient. So clearly the therapeutic protocol needs, the entire vision needs to be changed accordingly. And The important factor is during the first visit already to plan the interdisciplinary prosthetic strategy. Why? Because right from the outset, you need to recreate the proper neuromuscular attitude. And the simplest thing is to start by the tongue and motivate the patient well to understand its importance, functional importance, and that will, of course, help him to co-create and contribute. In other words, we use the froggy in order to motivate and stimulate our patients precisely. That will force them to activate the tongue throughout the mastication in order to retrieve the mastication proper triggers, because it's always very difficult and complicated to explain to the patients the relevant role of the tongue. It is used on a daily basis, as I said, for adaptative purpose. And it is only by doing that you understand fully the complexity of the system. Otherwise, it is hard to believe even how the most absurd systems are still always able to reorganize themselves. And we need to recreate the whole memorizing and engramming program. And we should not trust the adults just by dint of the fact that they're adults to understand theoretically what's going on and integrate all these elements. It is, after all, theory and experience confronted to one another that bring the best results. And I always say 100% the deglutish, the swallowing issues and problems will not be solved by a magic wand, but you need to understand first consciously, clearly, and then make sure it is integrated by your unconscious reflex system. So the patient will change, thanks to the froggy mouth, the position of his tongue. So basically, we've got to make sure that the patient is brought into the motivation program, and it requires a little more prior explanation perhaps than for the child, but the simple use of this device will help him change his attitude and generate some pretty fast results from a neuromuscular point of view. So we shall now have a look at a case that from a therapeutic point of view is quite similar, although being different. Why? Because we'll look at Mr. Luigi, who came to me to improve his aesthetic concerns and issues. But again, as I said from the beginning, you have to start by asking yourself why he became as he is. What happened since the time of his birth? What came about through his development, growth, and adult lifetime to bring about such mouth and oral structure? Why did those dysmorphoses came about? And that is how we decided. We tried to understand who sculpts basically this change.
So this is how it was created, and clearly the bacteriological factor and the hypofunction of the system is even more important than this type of cases. So patients come to us to improve the aesthetic part, but we need to find new structural functional system. So after the first visit, we always carry out an analysis, because this is the beginnings, and then we carry out an analysis of the tongue to try and make understand how important the tongue is in the process, and we also have to relate and make coherence with the interarchate, with the transversal shift based on the radiography and the pictures. And after the first visit, I would ask to go more in depth with further visits, and working alongside with my partner, Andrea. We'll carry out more tests, zebras, and assessing this type of system, because those patients are complex, and we can simply not carry out the usual routine. But we understand that the aesthetic motivation is there alongside with the swallowing, and you can see on the right-hand side the change that took place with another patient, and the results that we'll get after the first visit is, designing this aesthetic design, and see how we can modify things in the interior region because of what it lost when the wisdom tooth came out. So we'll explain, Luigi, that we'll carry out a modification with orthodontic, and we'll improve the restorative part, and then we'll have to treat him and make sure we rebalance his tongue right away, so he will do a change in the three-dimensional position of the teeth. It's a protocol, a paraneuromusical flash protocol with the Froggy, and we have to change the position of the teeth with orthodontics, always to improve the result as much as possible. We use this period of treatment to do all the regeneration and implants behind. This is the first orthodontic phase, and once we have already improved the previous situation, we will try to improve a little bit with temporary direct composites, and we'll give back the smile to this patient who is celebrating his 60th birthday. We do an orthodontic refinement during this time. We can further improve the healing of the bone, and the sinuses are clear. We take care of the lower vertical augmentation, and he has to place impacts. When everything is ready, we will take care of the posterior rehabilitation, which is fundamental. We have to support the mouth, and we'll look at what's going on, and we make the combinations for the implants. We realize that the teeth have to stay inside of in the proper place. And it's clear that today we have the possibility to plan that ahead. Afterwards, if I have doubts in terms of consistency, well, we'll see. I am a little bit skeptical, like Thomas, and we'll check anyway that the good housing is correct. We're going to make the clearest faces in the world, because Luigi does shows in Rome. He's quite famous here. And he wanted the widest teeth possible. We corrected the final result, and we tried and find posterior stability and a coherence interarch coherence with the U-shaped arches that gives Luigi the possibility to stew correctly. We freed the inner construction, something we didn't do with Lucia. We gave disclosures in advancement, small vertical disclosures. We tried to obtain a disclusion alternating mastication. As we learned from Mr. Legal, an incredible person, by the way, whom you will have the opportunity to meet, will learn and to see the patients eating. This means to understand if we can have a recovery of the masticatory cycles with the speeds, as Dr. Savalat proposed, to see the more extreme systems of mastication, but also with the harder products to which the patients must get used in order not to lose the function that they have recovered, and to give implants and the teeth a long-term periodontal resistance. It is clear that the whole system must be protected by bites such as the one from the Dr. Reals, which is great because it will fill all the defects that we prosthetists create, because we will never be able to support system at a 60-year long system. And we don't have time to talk about this. We will continue with the Froggy, because I believe that, as Dr. Romano said, that you have to insist anyway not to lose the habit. And in my opinion, we obtain a nice final result, even if a little extreme from the aesthetic point of view. We have to control the disclusion and the mastication. And we have recovered from a previous extreme situation. So we need to be careful to the system, that the systems are correct in the long term. Because we are operating a huge, we are also control the masticatory functions with the bite to monitor the patient swallowing and the functions and the dynamics in order to act on any consideration errors, because we are operating a huge system change. We cannot be sure, even if we have the best articulator in the world, we can never know how the system will respond to the change in mastication. Just to conclude, it's always the same protocol. Rosanna comes to us. Why does she have dysmorphosis with such wear and tear? What happened in that mouth? Apart from the erosion and the esophageal problems and the peculiar psychological history of this patient, what happened? Why did she age like that? And how will she age if we do a restoration? What is the role of the tongue in Rosanna's development of such explosive system, and what will happen in the future? So we have to take all of this into account. And so what did I do? I did I carried out a general analysis. I looked at the breaks right away. We will treat the patients first from the point of view of the neuromusculator of the tongue. We will carry out a surgical treatment. We'll start the Froggy. We'll make the tongue evolve from the beginning of the treatment. We'll study how to restore the system in a biological way. So we'll take measurements. We'll increase the vertical dimensions. we'll do a prosthetic. We'll do what a prosthetic does every day. It's always the same thing. That's not what we're interested in, because we've been doing this for 30 years. So we make walks out. We make them in digital or in analog mode. We define an average increase of the system. We will repeat as a test. It's a mock-up because it's a test to show the patient what we can do to start improving. We'll check that we have reduced on the joint is more or less coherent. Otherwise, we make small adjustments and we take up the vertical dimension and the centric relationship already in the study phase. Then we define an aesthetic improvement, but we leave spaces below, and we'll start and think that there was an inclusion towards the outside. But if we were to actually go back to the mouse as it was when before the wear, we should close down completely, like we did with Luigi back in the day. So what did we learn? We learned not to make big invasive contractions for the tongues, and even now we managed it better because we want to keep the neutral. We have to ask ourselves if there are explosive systems, and if so, to respect them. We reconstruct healthy teeth. Nothing biologically negative is needed. We produce veneerly in the lab, and we'll stick them under the teeth, glue them under the teeth. We will reproduce a new ideal mouth. We can say temporary because we can always replace it when it's ceramics in the future, or with ceramics in the future, or keep it like to make it work properly. We'll ask Andrea not to do just a small orthodontic corrections to improve the internal relation, not to close the spaces, and partly to close the spaces only on the inferior part. We will always use the Invisalign treatment. Some patients have a hard time to adapt to this adjustment with the time. So ideally, that would be the final result. But you can see that she managed to have the right disclosive function, the right mastication function. She will look at the masticatory cycles. We are at the beginning. After orthodontics, you see that there are still some spaces at the bottom on the lower finger, and that we have to be careful because often they have nice masticatory cycles. Sometimes they still have cycles of exit because exit cycles that we need to make up and to recover not only the structure, but we protect the biology and we seek to recover the system. We will definitely improve the system in the future, but we have to try more or less already with the prosthetic rehab to obtain either the dental part, which is the cervical part. We have to visualize where there are still problems and try to protect the system with and to improve it. And hopefully the system will not only be pretty but functional and in a long run, and it will create a nice and easy chewing possibilities and will make sure to obtain a coherent swallowing because it's not always something easy. It's the swallowing is not completely eradicated with the facial, but this is why we have to keep them the bites. The osteopathy and the froggy, as far as I'm concerned, are also systems of maintenance over time. This means that we must try to understand that these are complex systems, and we're not sure of the resolution when we return with the prosthesis. This is why the bites are most of the time the right solutions. But again, the swallowing factor, trying to produce the right mimicry and control the foundation, as Dr. Fellows has taught us. We'll conclude to understand one thing. Every time we study cases, we must show the beginnings. We have to understand for each dysmorphis that what we have to do, what we have to try to understand, what we can do, and not complicate things too much, because otherwise the patients are refrained from reaching the final goals. The patients on the right is the same as the one on the left. I remember receiving a video from Rondolph with the proper masticatory cycles and an extreme bite. So, and he was refusing to do some surgery. So what can we do for patients that at that age of 50, 45, 60? We can try to improve the situation, but we have to be careful. We must give posterior support. We must try to have correct disclosure, even though the most advanced in the most advanced cases, we must try to recover masticatory sures. We must try to understand that the language must be the tongue must be educated. The two things will straighten each other, and the finals. We have to understand that we will always have, and there will always be problems. There will always be breaks, and the problem is not how pretty the ceramics are. After time, the patient will be able to eat. We know that here Anthony was jaw was totally twisted. He had completely lost his ability to eat and chew, and thanks to the interdisciplinary management of the treatment, we managed to recover something. There were a lot of damages. At the beginning, we recovered posterior stability thanks to the implant. We have recovered the interarch coherence thanks to the Invisalign. We don't have to thank the mastication and the bites to protect the systems. And today, at the beginning, I did not yet have the idea of the Froggy. I remember going to his place and saying that I wanted to give him another protection system, and this protection system is the Froggy. Why? Because he had already done the whole trajectory, the whole protocol. But we had not considered the tongue, and because I didn't had that in my head, and at the time it was my fault. I mean, it's how you learn. I mean, try and error. But in my mind, well, there's always the teeth, the structure, the aesthetics, and the ceramic. Now we have to start thinking about giving that information to the patient as well, even when it comes late. He couldn't swallow at first, but then immediately pushed his tongue up and started to understand a bit what was going on. Look at the saliva, how it is always in the presence of lower teeth. How much Golgi is going to accumulate there? How much? How far is the situation going to go? So we have to not only try, but and I'll conclude hopefully in time as a orthodontist, my message is about the importance of understanding the efficiency, the problematic of the tongue, and to have a tool that can be used in the continuity, and that would be very simple. I will rehabilitate the aesthetics, I will rehabilitate the functions, I will give a nice smile to my patients, I will remain protecting the biology. There is no there is no parameters that dominates over the others. That is not the function dominating aesthetics, and the aesthetics that dominates the biology, and so on. It's a human body that we have to reproduce in another system, which was not the one that had developed before arriving at reaching the age of 50. But we must try to explore the possibility that Dr. Phyllis has given it. It's a very simple but very effective tool. And after some years, I start to see, sometimes even unconsciously, that my patients are beginning to understand that there are things that need to be carried out in the long run, and that it's not a machine that you put in the patient's mouth, and that it's of no consequence. But on the contrary, we have to start anticipating already in the planning where the weak parts of the systems are going to be, and show simply competence. Patients must benefit from our competence and perceive respect, the respect that we have for them. Because these are artificial systems, and we cannot be so arrogant as to think that we can put teeth in their mouth, be sure that they will chew, swallow, survive, and never have problems, and so on and so forth. So thank you for your attention. Thank you, Guillaume. If there are any questions, I'm here. Thank you very much, Antonello. We still have we're going good in terms of timing. We have 10 minutes left for the Q&A session, and the first issue I have here is that with good quality conference, well, people don't ask questions, they actually only congratulate. In fact, if I look at the chat, I have many more congratulations than questions. Here I have only one word: bravo, Claire Trochu, whom I know well, and who is however very interested in children and a little less in adults. Thank you for your perfectly clear and synthetic presentation. And Agnes Ferrand says this doctor is extraordinary, is outstanding. I hope that we will be part of the replay, so I can already tell you that Antonello's conference will obviously be part of the replay, as I am a big fan of his work. And we organize events like this. We enjoy it. We take pride in doing such. To get back to more practical questions that came up, well, we had a question. One of the participants asked us if leaving this small opening at the level at the 46 had not really also contributed to the maintenance of atypical swallowing. Absolutely. Lucia is the case that I use precisely to understand the evolution that I followed. One doesn't start with all the skills. It's quite the opposite, quite the contrary. What's interesting is, with Dr. Phyllis, that gave us a gift of having this new treatment capacity. So to get back to Lucia, if we contracted the arch excessively to recover all the diastemas, and at the time I didn't have that all of this in mind. I wrote articles about the high passive eruption, and why? Because he had an altered eruption of the interiors, so the teeth were small. And I wrote this article in 2016, and you can find that on the internet, on the gammism and the short syndromes, in which I explain. And because I would have, on the case with Lucia, I would have left the mouth slightly higher, relaxed, less contracted. I would have lengthened the lower teeth to recover a hat with ratio aesthetically coherent for my final veneers, and I could have put immediately a step, and that is a bit of a pity because she never put the implant. So we did not recover a bilateral chewing alternation on the tooth. So the most important is on the final aesthetic visions and so on. And today I can say that Lucia looks much prettier with a very simple smile with a 6 facets Invisalign. We changed her life, honestly, and we had changed her life without plastic surgery. And she was a pretty girl with a lot of teeth, but I also had left a lot of problems. So that's why I pointed out at the end that we have to try to treat these patients because we just have to try our best. But we need to be careful. We need to use these tools because it can definitely change your life, and it provides you with general protection of the system, and that will get to modify it in an incredible way. But besides, be careful because we cannot carry out too complex things, because if we have to do a rehab for every single person, 2,000 diagnoses, very complex, and then not being able to carry out the follow-up, because this is part of the diagnosis and the consequences. We need to create a certain balance here. Well, thank your patients. Do thank you for not always respecting what nature gave them. Well, one day of the or the other, someone took away my driving license, and since then I try to control my mistakes in a timely fashion. We are people. Doctors are people who are trying to look for cares. We have a lot of questions. We'll try and take them rather quickly. We'll publish your article, the article you just mentioned, on Facebook. A lot of the people told us that it was impossible to have an implant move with aligners, with alignments. No, I wouldn't. I never said so. No. I do move teeth, and I place implants at the end of the treatment to support the posterior occlusion. I never said that I move the teeth with aligners. I don't think my partner did either. So just to be clear, it's not about moving implants with the aligners. Okay, very important clarification indeed. We have an additional questions. How should the tongue be positioned at rest normally? Well, on the palate. Your father told me a very interesting thing. Not only taking care of the swallowing with the froggy, but you have to go and stimulate the gloss, because it will be reinforced, and on the posterior, of course. And actually, I have a good friend of mine that will speak later, provide this piece of advice. The tongue is a princess, and so her place should be in the palate. You're right. So last question before we go to Pietro Manzini: does the increase of occlusal vertical dimension also take into account the intra-auricular vertical dimension in evaluating function, or also from the point of view of imaging? That's a good question. So generally, prosthetists have always tried to figure out how to position correctly the mandibles. So what are the systems helping here, since Jack and all the others tried everything? Normally, I I would agree with Mr. Legal that the darker thing is to go, the important thing is to go back to the function the nature gave them. We're here in an orthopedic relationship that is more coherent, and this is why it's very important to recover the swallowing at the beginning of the treatment, because if I have to let's say, and I do it often, I use the coherent swing to look for a three-dimensional position of the arch with the center breaks, and I learned from all the groups of the brigade functions that I had presented before, and I would need to increase, and here you can see that I can do that with the coherent swallowing. I'd be very interested to understand with very complex systems and radiographic analysis the three-dimensional position in the joint. But honestly, Guillaume, things needs to be coherent. I cannot make it too complicated. So sometimes in congresses you hear wonderful things, but it becomes, it's not realistic on the daily practice. Given the nature, it has functions, and we know that when we cover mastication, when I have height problems, I put a bite and I do supervise the patients during the treatment with the bites, and when the bites gradually adapt, and it is going to recover, and the tongue, the tongue with the froggy, and we have here a system. This is not a fixed system; it's an X. So according to me, using an X-ray or an articulator to fix and crystallize a system is not a good idea. This would be a mistake. So we get back to the functions for to guarantee our capacity to recreate coherences, and this is why when I talk about neoplasticity, it helps us because it creates this change. So we have a lot of questions popping up. This is because your conference was quite unique. All these questions will be addressed on our Facebook page, because I can see that we're running late. We'll carry out a fast transition. To leave our translator, to give our translators a break. Thank you very much for your conference. It was wonderful. I knew that it would be this way, but again, the comments on the chats are proving how right I was. So let's meet on the platform and then on the Facebook group to continue this discussions on Tello's conference, and in order to get the last answers we didn't have time to address before. I just wanted to say that all these aspects will actually be tackled on the next conferences. We'll organize more conferences in the very near future. And we'll now talk about myofunctional therapy. Thank you again, Antonello, for this wonderful conference. Thank you very much.